Hello, everybody. Welcome back to the Incubator and Neonatology Review podcast. It is now Friday. Daphna, how happy are you that Rooney is helping us out?
I'm so happy. And I'm learning a lot. I don't particularly like reviewing cardiac embryology, so I found this very helpful.
Yeah. Rooney, how are you?
Oh, I'm doing great.
Yeah? What are you talking to us about today?
We're going to continue on embryology. We're going to review a little bit on left-right differentiation right up front. And it's just...
Okay. Well, for people who are who haven't paid attention yesterday, all these are actually recorded also in video. And will be available on YouTube as well, where we have all these slides up. So
that's good. Yeah. All right, guys, thank you so much. So in the last episode, we talked quite a lot about left-right differentiation, some genetic aspects. I feel as though clinically this is very pertinent. So I just want to talk a little bit about the clinical presentation of the lack of normal left-right differentiation.
And so, what do we mean by that? Actually, left-right differentiation.
Yeah.
What is the differences? I mean, isn't there two atria and two ventricles? I mean, what's the intrinsic difference that, as a cardiologist, makes you say, no, that's very specific to the right side. That's very specific to left side heart.
Yeah, exactly. So I guess kind of what I tell medical students that on the outside, we seem pretty symmetric.
Yeah.
But on the inside, the more symmetry you have, the more abnormal your kind of organs are organized. So you're supposed to have asymmetry internally. And I'm going to talk about those, but from a cardiology standpoint, that asymmetry is often related to, again, cardiocentric, but the atria. Okay, so you have a clear morphological difference between the left and the right atria. So here on this picture, you see the right atrium, and you have these papillary muscles, which are very trabeculated, and they go all the way up into the right atrial appendage. The right atrial appendage is pretty small and shallow, but throughout you have these papillary muscles that almost all end up in the cresta terminalis, the CT. That's right here, the terminal crest, which is the border between the primitive atria, the original atria, and the venous aspect, the sinus venosus that comes in from the back. So here on this part, you see the SV, which is the sinus venosus, which is really from the back side of the primitive atria. It starts the sinus venosus and kind of folds itself in and kind of spreads the entire atria to the side, and the old atria kind of goes up to the top and forward, and which makes it so that the right atrium becomes smooth, right? Mm-hmm. But the old part of the atrium, the right atrium, is not smooth. It's very trabeculated. So not infrequently in the cath lab, as in the fellow, you will come up with a catheter up through the inferior vena cava. The classic place where you will get stuck is in the right atrial appendage. Mm. And we should know that too as neonatologists, because you can put the umbilical vein catheter up, and if it does get stuck in the right atrial appendage, if you push too hard there, you can perforate the right atrial appendage. It's just like an anatomical thing. Yeah. But in the left atrium, you have no cresta terminalis, and you don't have these papillary muscles that kind of go into the atrium. And the left atrial appendage is much, much kind of more, it's thinner and is longer. And that's why you can say, see easily why a thrombus, for example, so with atrial flutter, thrombus can be formed inside the left atrial appendage and less so in the right atrial appendage.
That surface area is so big.
Yeah, yeah, and it's deeper, kind of more finger-like.
Yeah.
So when we talk about this, we often refer to it as left atrial isomerism or right atrial isomerism. That means that you basically have either two left atria or two right atria. And this is kind of an overview that includes other organs. But on the far right, you have the usual arrangement. This is all under the bucket of heterotaxy, right? So your usual arrangement is that you have a right atrium on the right side and a left atrium on the left side. The right pulmonary artery is known as eparterial and is shorter. And the left pulmonary artery is known as hyparterial, kind of goes over the left bronchus. So if you look at the pulmonary arteries, the left pulmonary artery actually goes immediately backwards, where the right pulmonary artery actually takes a 90-degree angle as it goes right. And obviously we have 3 lobes on the right side, and you have 2 pulmonary lobes on the left side. And obviously we have a right-sided liver and a left-sided stomach and spleen. So if you have a mirror image, all these things are switched completely. If you have right isomerism, you will have 2 right atria. You will have 2 eparterial pulmonary arteries. You will have trilobed lungs bilaterally, and you will have a middle, kind of a midline liver. You will have absent spleens. Mm-hmm. If you have left atrial isomerism, you will have 2 left-sided atria, finger-like kind of appendages. You will have 2 hip arterial pulmonary arteries. You have 2 bilobe pulmonary lungs, and you will have multiple spleens, like polysplenia.
Polysplenia,
yeah. So again, that's kind of important to know as part of this is a result of this early aspect of embryology when the cilia comes up, right? Mm-hmm. So then you have almost by default some form of ciliary defect because you haven't been able to establish this left-right kind of differentiation. So if you hear that someone has a splenia syndrome, then you can say, oh, this is right atrial isomerism, okay? Because then you don't have a spleen. Know that the right atrial isomerism has slightly higher mortality. It's never associated with an interrupted inferior vena cava. It can be associated with total anomalous pulmonary venous return. It's not infrequently associated with pulmonary atresia. And it's the highest risk of malrotation because similar to left-right differentiation of the heart and the lungs, the intestines has to be packed in correctly.
Right.
And you will not have that organization of the intestines. If you have a left atrial isomerism, you also have, it's also known as polysplenia syndrome. Mm-hmm. It has slightly lower mortality than the right atrial isomerism. In this case, you will have an interrupted IVC, not infrequently associated with single ventricle physiology. We often refer to those. Those are not your hypoplastic left heart syndrome, and they're not your tricuspid atresias, right? But they're often your univentricular hearts. Mm-hmm. Okay, so unbalanced AV canals or single ventricles with some form of other anomaly, and frequently, not infrequently, kind of coarctations or outflow tract obstructions. These have a lower risk of true malrotation as well, as compared to right atrial isomerism. But any baby that has, some form of isomerism or heterotaxy should have malrotation as part of their underlying kind of partial workup, if you will. Mm-hmm. Yeah. And upper GI obviously is the key for that. So I feel as though clinically we see these in different layers. We don't always see a full-fledged heterotaxy syndrome, but this is a common finding, I feel, in the NICU. Someone has placed a PICC line, and you're asked to look at where on earth is the tip of this PICC line.
Yeah.
Where does it go? And it I don't think a picture like this would show up on the boards, but it's interesting. So here is obviously a PICC line that comes from the left arm, goes up through the axillary vein, goes to the subclavian vein, and then all of a sudden it goes down on the left side. It doesn't bridge over to where you would expect a normal venous anatomy.
It just crosses over.
Yeah, so there's no innominate vein, basically. So the innominate vein connects your subclavian, your left subclavian to your superior vena cava, basically. But that doesn't exist there. So it goes down a left superior vena cava, left SVC, and almost per definition, a left SVC will join with the coronary sinus. So it goes to left SVC, goes into the coronary sinus, behind the heart, and into the right atrium, and then somehow managed to go down through the right atrium, down into the hepatic portion of the inferior vena cava, and somehow got stuck down there in the smaller hepatic vein. But anyway, so this is a classic left-sided superior vena cava, which is, again, should prompt some degree of suspicion for heterotaxy, because this is not your normal left-right differentiation.
Right.
So these are, and they do pop up every now and then. Very well. So that's, again, little kind of clinical associations when it comes to this left and right sided differentiation, which I think is important. Back to cardiac embryology. We were talking about the heart tube and kind of the images of the heart tube. And now the next step is looping. Looping actually doesn't necessarily occur because the heart tube bends or turns. Looping is a result of cell mass growth. So basically, since the cardiac tube is tethered from above and below, when aspects around the tube starts growing, then it's pushed to the left or pushed to the right. Okay, so as it also becomes a little longer, this occurs at 21 days. That's kind of, again, a little bit of a marker there, and it bends to the right. So if there's any kind of a normal looping, is looping to the right. Looping to the left is abnormal. And the reason why it loops to the right is because there's left-sided proliferation of cells. So all of a sudden you have this growth of cells on the left side, which basically makes the cardiac
makes it tilt almost.
Kind of tilt over to the right. Okay. So just remember looping to the right.
Yeah.
And there are two aspects of it. It's the C looping, where the heart bends to the kind of the ventral side to the right, secondary to these additional myocytes. But then also, actually, more in the ventral aspect. And then you have the D looping, which is the rightward turning of the heart, again because of the growth. And this aspect of looping and the growth of these cells on the left side is, remember how we said that all the genetic factors, serotonin, everything goes to the left. And so this has kind of been brewing and getting ready for this aspect of cell growth. And that cell growth, again, I think happens pretty much almost overnight and causes this almost explosion, and it's called ballooning. And that ballooning aspect is actually just this massive proliferation of myocytes. Okay. When this happens, this is another interesting aspect, is that the cardiac tube has, we talked about it, the myocytes in there kind of contract on their own. Okay, they're kind of the slow depolarization type myocytes that's kind of have a pacemaker type and kind of depolarization, where the new cells are your rapid depolarization myocytes. Okay, and this sets the stage for the cardiac tube basically being eaten up by these new myocytes that are growing both from the ventricles and from the atria. Mm-hmm. Ultimately, what this results in is that the cardiac tube becomes the conduction system. Okay, so what starts off as a cardiac tube ultimately ends up being embedded in this mass of new myocytes, mm-hmm. and is the conduction system. As there's looping and more proliferation, then there's this unique kind of a turning of this conduction system that ultimately makes it so that it becomes the conduction system that we know. So that's looping. Another thing they tend to, another term that they like to use in the boards that I've found is something called convergence.
What the heck is that?
I know, and it doesn't make sense. It's not a word that makes sense, right? So as the ventricles become deeper, the inflow and outflow tract are brought closer. That means that you have, in the beginning of kind of the tube, you have the common AV valve is here, and the common outflow tract is here. But as you start having kind of the growth of the ventricles, the inflow tracts and the outflow tracts actually come closer together, and that is known as convergence. That means that you basically your heart becomes more structured. Mm-hmm. Okay, and not infrequently in cardiology, you look at the relationship between the inflow valves and the inflow tracts and the outflow tracts. Mm-hmm. Okay, so especially on the left side, the kind of the outflow tract of the aorta is shared with the inflow tract of the mitral valve. Okay, it's a shared membrane. Okay, and if you don't have that shared membranes, then and you actually have muscle tissue in between there, you actually have a diagnosis of double outlet right ventricle. So this is very important. So convergence is an important aspect of actually having a normally structured heart in that sense, and puts the atria in the right position, and the truncus arteriosus, which is going to separate into the aorta and the pulmonary artery, kind of puts its position anterior in the heart, but kind of wedges in between the inflow tracts. So we talked about looping, convergence, and during this stage, kind of the fourth week of life, you have this kind of rudimentary circulation. Okay, so now you have a circulation that's a circular circulation that really goes from the right atrium to the left atrium to the left ventricle to the right ventricle and out through the truncus. Okay, so as part of this aspect, you can imagine what still needs to happen. We need septation, right? We need the atria to septate. We need the left ventricle and the right ventricle to septate from each other, and the truncus to septate into the pulmonary artery and the aorta. On the slides right now, I do have a little thing about the ballooning, because I do find the ballooning aspect kind of fascinating. So you can maybe show that at the same time. But I'm not going to review the ballooning aspect. So let me see. I'm going to go straight into I said septation is coming up. wedging is another aspect. Okay, and wedging is another term that's not infrequently used in the boards. So what is really wedging? So again, we've had the atria and the outflow tract come closer together, and the inflow tract and outflow tract, and now as part of the septation of the truncus, the truncus basically is embedded in between the two atria. Yeah. Okay, so that's really the beginning aspect of the wedging, in that it kind of pulls itself in, so the atria kind of embraces in some ways the truncus, but then at the same time you have the conotruncal tissue, which is really muscle tissue. So if anyone talks to you about the conus or the conal truncal area, it's basically myocytes. Okay, but there are myocytes that are associated with the pulmonary artery. Okay, so the pulmonary artery is embedded in the conus. The aorta less so. Okay, the aorta should not have conus around it. It can have part of it, but not around the entire aorta. So the conotruncal area is the pulmonary artery. And then what happens is that the conotruncal tissue, as the right ventricle and the left ventricle grow, the muscle that embeds the pulmonary artery kind of makes a pulmonary rotate anteriorly, and ultimately ends up kind of behind the pulmonary trunk, kind of gets wedged between the AV valves, and the pulmonary valve turns into be the most anterior structure of the heart, right. And anterior and slightly to the left of the aorta. Okay, and that rotation and counterclockwise about 45 degrees supposedly kind of move the pulmonary artery anterior and leftwards to the aorta. And that whole concept is partially resulting from the septation of the truncus, but that whole concept is called wedging. Right. So if there's a question about wedging, you know what that means. This picture on slide 52 really describes the morphology and the association between the inflow tracts, the aorta smack in the middle, and the pulmonary artery, which is anterior and slightly to the left of the pulmonary, slightly to the left of the aorta. Here you can see how the aorta is kind of wedged in between the mitral valve and the tricuspid valve. That's the wedging aspect of it. Other part of the wedging aspect is the movement of the
in the pulmonary valve.
No, the aorta. See how the aorta kind of makes a V in between the two inflow tracts, the mitral and the tricuspid.
So what we're looking at is the top portion of the picture shows the pulmonary valve.
Yep.
And that's anterior.
That's anterior.
And then you go posterior, and then you see the aortic valve.
Correct.
And then the two, the mitral and the tricuspid.
Exactly. Yeah. So if you were to cut from the front, the first structure that you hit is the pulmonary artery. Yeah, exactly. And so the fact that the aorta is kind of wedged in between the tricuspid valve and the mitral valve, that's kind of the wedging aspect.
Yeah.
Okay. So now we've done the looping, convergence, and then the wedging. And then now comes your favorite part, Ben.
Septation.
Septation, yeah.
Do you want to go over septation now, or do you think we should take a break and then resume tomorrow?
We could take a little break.
All right. Yeah. Daphne, do you have a question for us? Have we lost Daphne?
I sure do. I have 2 questions for you guys today. Okay. The first is going to be a tough one because I did not recognize most of these syndromes, but maybe you will. Maybe Rooney will.
Yeah.
Okay. This is ID and Immunology question 83. Each of the following disorders can be associated with congenital asplenia except A, Ivermark syndrome, B, Pearson syndrome, C, sickle cell disease, D, Smith-Myers-Finneman syndrome, or E, Storr-Morkin syndrome.
So the question asks which of the disorders is associated with congenital asplenia, and you want to know the outlier. You want to know which one except. And you have Ivemark syndrome, Pearson syndrome, sickle cell disease, Smith-Myers-Feynman syndrome, Storm-Morgan syndrome.
Which one of these is unlike the other? That's the question.
Can be associated with asplenia. You know what? I'm going to go sickle cell. I don't know. I don't remember sickle cell being associated with asplenia. I don't know the others. It's not like I'm very comfortable. That's right. Ivemark is clearly always coming.
That's right. You know, sickle cell is related to the spleen. That's why it's in the question. But sickle cell disease is a right. But we're looking for asplenia, right? Yeah. So congenital asplenia. So sickle cell disease, as we know, is a hemoglobinopathy that causes red blood cells to sickle under certain conditions. And over time, the spleen auto-infarcts, making patients with sickle cell disease functionally asplenic. But that wasn't the question. The question was which, that was the point of the question. Which one of these does not have congenital asplenia? So you're right. Sickle cell disease is the right answer. But I think it's great for us to review these other syndromes, so at least people have heard them, that do have congenital asplenia. So Ivemark syndrome, a rare autosomal recessive disorder with features of asplenia and either dextrocardia or a right-sided aortic arch. It's also known as asplenia syndrome, heterotaxy syndrome, cardiosplenic syndrome, right atrial isomerism, or bilateral right-sidedness. Pearson syndrome is a bone marrow failure syndrome that causes sideroblastic anemia, thrombocytopenia, and in some cases, asplenia. Storm-Morgan is also a rare disease that consists of asplenia and thrombocytopenia, among other features. Smith-Myers-Feynman syndrome is X-linked recessive disorder and involves asplenia, cryptorchidism, and severe intellectual impairment.
Okay.
Rooney, have you seen any of these? The Ivemark syndrome?
I've never called it that, but I've seen plenty of left and right atrial isomerisms. And yes.
Didn't stick around for genetic testing.
I just looked at the heart.
That's right. Okay. One more question?
You want to save it for tomorrow? We're way over time.
I know, but this one's so easy and it's so fun.
Okay, fine. Go ahead.
Okay. This is the ID and immunology question 81. You are caring for an infant with heterotaxia asplenia. As a precaution, you initiate antibiotic prophylaxis to prevent infection by encapsulated organisms. Which of the following is not an encapsulated organism? Is it A, Haemophilus influenza, B, Neisseria meningitis, C, Pseudomonas, D, Salmonella typhi, or E, Streptococcus pneumoniae?
We should really keep track of the questions we're doing because I think we did this one already on the podcast.
I know, but that's a good one to hammer home.
Anyway, I think
that you have a mnemonic for.
I know we have shins. I'm going to let you go over it. I think Pseudomonas is the one that we do not cover for, right?
That's right. So shins, we think of a shin guard in soccer that help protect us protect the bacteria, certain bacteria that are covered in this polysaccharide capsule, which helps them evade cell-mediated immune response. So that's Salmonella typhi, the H is Haemophilus influenza, the N is Neisseria meningitis, and the S, Streptococcus pneumonia. So you're right, Pseudomonas is not an encapsulated bacteria.
You happy we did your question?
Okay. Yeah, I am.
Okay, good. All right, guys, we'll see you tomorrow.
Thank you.